morning, good afternoon, and good evening to our wonderful speakers, chairs, and audiences in different parts of the world. We welcome you all to this first webinar in the month of September 2021. The first speaker for the session of today is our honorable guest from Italy, Professor Edoardo Boccardi. Professor Boccardi is the Director of Neurointervention Neuroradiology in the Niguarda Hospitals in 2002 and Director of the Department of Neuroradiology in Niguarda Hospital since February 2009. He is one of the senior faculties dealing with endovascular procedures and has been proctor for the first experiences with coils, stents, glues, flow diverters, and treatments of neurovascular diseases since the mid-19th in several hospitals and university centers in Italy and rest of the Europe. He is a vastly experienced endovascular surgeon who attends 500 procedures per year as principal operator and as teacher or tutor for the treatment of intra and extracranial vascular diseases, namely aneurysms, AVMs, fistulas, angioplasties, stenting, thrombectomies, etc. He also operates upon spinal cord diseases, including in children and newborns. We are extremely honored to have him today as a speaker at our webinars, and today he'll be talking about endovascular treatment of vein of Galen malformations. The speaker for the second session of today is our honorable guest from China, Professor Wei Shi. Professor Wei is the consultant neurosurgeon in the Department of Neurosurgery at the affiliated hospital of Nantang University, Jiangsu, China. He is the vice chairman of the neurosurgery branch of the Jiangsu Medical Association, as well as the vice chairman of the neuro-oncology committee of the Jiangsu Anti-Cancer Association. He has been active in the field of neuroendoscopy and has vast experience in dealing with microvascular decompressions under endoscopy. We are extremely honored to have him today as a speaker, and he'll be talking about full endoscopic application of microvascular decompression in trigeminal neuralgia and hemifacial spasm. The chair for the first session of today is our honored guest from Japan, Professor Masaki Komiyama. Professor Komiyama is the director in Department of Neurointervention, Osaka City General Hospital, Osaka, Japan. Professor Komiyama reserves his subspecialty in cerebrovascular diseases, pediatric vascular diseases, hereditary hemorrhagic telangiectasia, head and neck vascular disease, and neurovascular anatomy. He is a very well-known research scholar who was also the past editor of Journal of Neuroendovascular Therapy till the last year. He is a member of the Japanese Society of Neuroendovascular Therapy and the Neurosurgical Society, the Japan Congress of Neurological Surgeons, as well as many important several international organizations. We are extremely honored to have him today to chair the session of Professor Boccardi. The chair for the second session of today's webinar is our honored guest from Japan, Professor Fuminari Komatsu. Professor Komatsu has been an endoscopic specialist in the Department of Neurosurgery at the Banbantane Hotokokai Hospital, Fujita Health University, Nagoya, Japan. Professor Komatsu is a pioneer in the field of endoscopic MVD surgery and has published several operative videos in his dedicated online channel. We are extremely honored to have him today at our webinars to chair the session of Professor Wei Shi. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kacho, I would like to welcome both the speakers and chairs, as well as all the audiences to this online platform of ACNS webinars. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to our first chair, Professor Masaki Komiyama.
Okay. The first topic today is vein of Galen aneurysm. It's a great pleasure and an honor for me to share the Professor Boccardi is going to present this interesting and very difficult vascular disease. In the past 20 or 30 years, great improvement of the treatment, maybe understanding of anatomy and also physiology. And the neonatal care has also changed. But still, this disease is very challenging for us. It's a great pleasure to listen to the state-of-the-art management of this difficult disease by Professor Boccardi. Could you start the lecture?
Hello, everybody, and good morning, evening, afternoon. I'm very honored to be here. Thank you for the invitation. So I will talk to you about vein of Galen aneurysmal malformations today. And of course, first of all, my conflict of interests. I'm a consultant for more or less all the major companies, so I don't want to make a list of it. I will start by telling you a story. This is a story of a beautiful girl who now is 24. Her name is Sarah. And a couple of years ago, she graduated in biological sciences. But once she was a newborn baby. This little lady was born on 20 September 1997. And she comes to our hospital at 4 months because she has an initial heart failure. And the heart failure is due to a high flow AV fistula in the center of her head, which is this black balloon that you see in the center of the head of this little baby. This is a vein of Galen aneurysmal malformation. And what you can see here is what we see on angiograms. So there are vessels which come from everywhere and go into this big chamber in the middle of the head. And this is the frontal view of the same disease and lesion. What did we do in 1998? We placed coils in the big supplier, the afferent to the malformation, which is where the AV shunt is. And coiling at the time was, well, not at the beginning, but still early stages. But we could place coils there, occluding that supplier and that afferent. And then we placed the glue in some other smaller vessels still going inside the same dilatation. So using coils and glue is still something that we do today, as you will see. This was the images that we had before doing anything. And at the end of the procedure, we finally got this other images, which of course still show some shunts into the dilatation, but it's much, much less than before. And especially it's the speed which is less. And you start to see better the normal vessels of the brain. So her heart functions were normalized. She develops normally, but the fistula is still there. And this was when she came at 4 months. And at 4 years, you can see that there are still vessels in the center of the head, still much smaller than before, but still there. Again, this is what we saw at the beginning. At 4 years, as you can see, there is still some AV shunt where there was the malformation at the beginning. So we decided to treat her again, this time using glue in the vessels that were still going there. And we left it with a small residual. This is her when she was 6. So she's really developing absolutely normally. At 9 years, in 2007, we check again and we see that there is some residual still. So we decide to get more aggressive, and this time to occlude the vein with coils through a venous approach. So we get there with a catheter, as you can see, and add the coils in the vein. At the end of the procedure, we don't see the vein anymore. And so now we did 4 treatments, and we think that the fistula is cured, probably. So finally, we occluded the vein of Galen malformation. Not really so. So we keep doing follow-ups, hoping there might be a spontaneous complete healing. At 13 years of age, in 2011, there's still something. So we wait, we keep watching. This is what we have at 13 years of age. In the meantime, luckily, she's developing absolutely normally. She's an excellent student. She's doing sports. And at 18 years, so when she, in 2015, again, a follow-up. And again, the situation is probably stable. We were hoping that it would go away by itself over time, but it did not. And so the high flow shunt is still there, as you can see, both from the plain images and from the MR angio images. In 2019, so a couple of years ago, she's 21. Same thing, probably a little bit stable, a little bit more than before. And together with her, we decided to look better with an angiography now. And what do we see? We see the shunt, arteriovenous shunt, still there 21 years later, as you can see from all the images here. So in 2019, at 21 years, we decide to go on with the 5th treatment, 21 years after the first. And again, we go with microcatheter and use glue, which is N-butyl cyanoacrylate, more or less what we usually use in our homes as crazy glue. And this is at the beginning of our procedure, and you will see that by using glue, all which is gray, dark gray in the AP and lateral view is the new glue. And at the end of the procedure, well, finally, we think it's done. No more shunt. Before and at the end of the procedure. So, of course, we know that we have been wrong before. So we do a follow-up, and this is a 2.5-year range of follow-up. She is now 24. And again, we can see that there is no more vein of Galen malformation. So we have achieved the complete cure at last. This was at the beginning when she was a newborn, and at 13 years, there were still vessels in that region. 24 years, no more. So she's cured. It took some time, but she finally won. Why all this story? Just to tell you that vein of Galen aneurysmal malformation represent a complex and difficult area in the interventional field, but it's extremely gratifying. And these are some of the children that we have treated in these last years, just to show that once you cure the fistula, well, the children have a normal development almost always. So it's very important to treat this disease because you can have wonderful results. What is a vein of Galen aneurysmal malformation? Whether it's arteriovenous communications, shunts, more frequently multiple shunts, usually high flow or very high flow, between arteries, which are choroidal and pial arteries, and the vein, which is in the region of the adult vein of Galen. But the vein is not the vein of Galen, is the precursor of the vein of Galen, and is called the prosencephalic vein of Markowski. Since it's before the vein of Galen, there should be no connections with the deep venous system, but often we can see them. So this is not a dogma. Just a couple of images to be more clear. In the normal adult, as you remember, the vein of Galen is in that region, collecting blood from the internal cerebral veins and from the basal vein of Rosenthal. And the straight sinus, of course, has an oblique direction towards the torcular. In the vein of Galen malformation, you have the prosencephalic vein in the center of the head, and usually you have a sinus which is horizontal and not oblique towards the superior sagittal sinus. And then you have choroidal feeders and pericallosal feeders. This drawing was done by Joe Bhattacharya, which is a very well-known expert in the field. malformations, vascular malformations in a neonate come in about 2.5 over 100,000 newborns. But less than 1% of these are vein of Galen, which is very, very rare. But vein of Galens are almost always symptomatic in the neonate because of heart problems. Pierre Lajonias, who's no more with us, he is the one who taught all the world about vein of Galen malformations, and this is one of his drawings showing the supplies and the arteries coming to the shunts. And so when you do an angiography, you can see that the pericallosal artery is entering from above, and the choroidal arteries often join the position in the anterior part of the vein of Galen, and then you have a transmesencephalic artery coming from the tip of the basilar artery. So you have multiple feeders in these situations, and even if the shunt may be just one or two or three. And then you have the falcine sinus, which is horizontal. Often you also have venous stenosis at the exit of the skull, so usually at the jugular bulb. So in the neonates, the presentation may be quite varied, but in a high percentage of cases, especially with larger shunts, there may be a rapid deterioration with cardiac failure leading on to multi-organ failure. So it's a very rapid and deathly disease. If you see them in infants and children, of course, it's because they survived the neonate period. And so when the shunt does not cause heart problems, children may grow up and later on present with hydrodynamic and or brain disorders, macrocrania, hydrocephalus, neurologic signs. Today, it is relatively frequent to the antenatal diagnosis, which leads to a better planning of the overall management. And so it's easy to diagnose in utero because of the big vascular pouch in the middle of the head is very clearly defined. This is important because now we can be ready when the child will be born and will be ready to assist him in a better way. So at birth, the first thing you should do is an immediate cardiologic evaluation and medical treatment if needed. And secondly, evaluate the possible brain damage. So we need to have an MR or a CT of the little brain. And so you have a CT on the top row and MR in the lower row, just to understand if there is a possible damage of the brain. Because in case of severe brain damage, what we call melted brain, of course, treatment is not indicated. It's better to leave it alone. And if clinically acceptable, so if the heart problem is not bad, it is better to delay treatment until when the child's weight is around 5-6 kilograms, which usually is 5-6 months of age. Why? Because everything we do inside the arteries and the veins of these small children is a little bit better to do it when the child is weight is bigger. The other thing you could do at birth is to keep the umbilical artery, because sometimes it's easier to enter the internal iliac artery from the umbilical artery rather than puncture the femoral artery, which, as you can see, is often very, very small, so difficult to access. I will show you an example case. In this case, we had to intervene at 3 months because of a progressive heart failure. And so we did an endovascular treatment. And here you see the microcatheter, which is on the left, it's the lateral view. and on the right is the frontal view of the same thing. So we get there with a microcatheter, which allows us to place coils. And in this case, we placed coils and glue. You see the coils, this little black filaments, and glue is this gray, dark gray element here. And what we achieve, this is before we did anything, and this is at the end of the procedure. We have still some flow and some shunt, but a lot of it has been excluded. And this allows the heart to go back to a normal situation. So when it's the end of intervention, we can see that the cerebral arteries may immediately auto-regulate to the new flow demands. You can see here before on the left here and after on the right, and you can see the difference in the caliber of these arteries, which on the right here, there is no more steel from the shunts, so the arteries may go back to a normal caliber. And this is also on the lateral view, the same thing, a change in the caliber of the arteries that go to the normal brain. And at the end of the intervention, you can also visualize the so-called limbic arterial arch, which is an embryonic communication between pericallosal arteries and choroidal arteries. So this is before the treatment. You see the shunt here, but you can also see that there's something here. Once you occlude the shunt, you see that from the choroidal artery, you get to the pericallosal artery, just something which may stay for years once the fistula is occluded. So you have the normalization of heart functions, and you can see the difference in heart volume before and after. In case of hydrocephalus, it's very important not to shunt. Do not shunt hydrocephalus in vein of Galen malformation, because the hydrocephalus is not a compressive hydrocephalus and not an obstructive hydrocephalus, but it's a hydrodynamic hydrocephalus due to the high flow in the veins. So you just have to treat the fistula. This is an example of a little kid that had a hydrocephalus with, you can see the transependymal passage of CSF in the brain. We treated, as you can see, the fistula, and just 4 days later, the hydrocephalus is much less. There is no more transependymal flow. Without any shunt. And why not to shunt? Because shunting may greatly damage the brain, inverting the direction of CSF flow through the parenchyma. So in these cases, do not shunt, but only treat the fistula. Another case, this is our first case of vein of Galen malformation treated in our hospital in 1995. Luckily, it was a very simple case. As you can see here, not a lot of vessels, but just one single point of shunt in the middle. We placed some coils there, obtaining the complete occlusion. And at 6 months, there was no more lesion and the child was okay. As I told you, if treated correctly, in most cases, the child develops normally. And here is the second case, is a 2-month-old little girl, which came to us because there was a hydrocephalus, as I told you. So we decided to treat her. And as you can see, again, here it was a simple case. We just needed to occlude these couple of vessels here. And we did it with coils again and some little drop of glue. And before, there was this very big pouch, and 1 year later there was no more, nothing anymore. Of course, the ventricle remained dilated, but with no problem at all. As you can see from these images, they show the development of the little girl. So as I told you, complete immediate occlusion of the fistula is not needed, but you should occlude it enough to diminish substantially the flow and allow the normalization of heart functions. Why not occlude it completely? Because sometimes it's too much for the little kid. So you have to respect the fragility of the small body. In this case, where we had a first treatment at 3 months, you can see here the fistula as usual, and images that you have already seen, lateral view on the left and frontal view on the right. We placed the coils and glue, and the fistula is still there, but the hemodynamic is completely changed. Now the flow through this lesion is a lot less than before, probably 90% less. You can see it's not completely occluded, it's a subtotal occlusion, but we don't want to go on with a complete occlusion immediately. It probably would take longer time, longer exposure to X-rays, a lot more contrast medium, something we don't want to do, and also we could cause a sudden change, which is too much. So that's enough to have a normal development. And at 2 years of age, we decide to complete the treatment. This is what we get at 2 years. We still see vessels in the middle of the head. And this is the angiography. We go on by injecting from this catheter inside this pouch. We injected the glue, as you see here, occluding completely the fistula and allowing this beautiful girl to grow and become, now she's 16. Do we cooperate with neurosurgeons? Oh, yes, but it's rare. Why? Because really it's mainly an endovascular problem. But in this case, 5-year-old little boy, he had a routine CT after a mild head trauma, and this is what they found. So there were calcifications in the white matter of the brain, and there was something in the center of the head. And of course, after the CT, he had MR, which showed the vessels, and then he had an angiography, which showed the fistula and the VGM with characteristic. We show that this is not a high flow fistula. That's why he was not diseased before. And we decided to, of course, go for an arterial approach and occlude as much as we could, but the arteries were small and tortuous, so we didn't occlude everything. We achieved a little bit of a diminished flow in the fistula, as you can see from the disappearance of the vein in that region, but there is still the fistula. And 1 year later, again, you could see the remaining of the fistula. So we decided to complete the treatment through a venous approach. But the problem is that there is no jugular access because the transverse sinus were occluded, both of them, towards the jugular veins. So we decided to have the help of the neurosurgeon who did a burr hole in the angiosuit, where I enlarged this region here, and you can see we came through there. We puncture with a needle through there, and you can see where we are. And then we placed the microcatheter, which allowed us to place coils, and finally get to the complete occlusion of the fistula. This is before, this is immediately after. A 3-year follow-up, everything is good, no more AV fistulas, and this is our friend here. So the treatment in the first days of life is quite complex because of the severity of the clinical picture. These are little kids who are very bad because of heart failure, and the fragility of the little body as a whole, and the difficult approach, of course, to arteries and veins, which are very small and fragile, and also the necessity of limiting the contrast medium. We arrived sometimes at treating the whole fistula with 9-10 cc's of contrast medium, and the necessity of limiting drugs, heparin, of course, and overall liquids. So we do it only if absolutely necessary, when the kid otherwise would die. And we don't go for complete cure, because the goal is to help the heart by reducing the arteriovenous flow. This was a small child who came in the first day of life. We had to do something because he was very sick. And this is the fistula. We went there with our catheters and we injected a lot of glue, really probably too much, achieving, of course, a good result from the shunt point of view. All while was for 16 hours, but then at 16 hours, he bled with a massive subarachnoid bleeding and died. A different bad outcome when this little boy came again in the first days of life with this horrible looking fistula. We hoped to do something for him, and we again injected the glue, as you can see, a lot all over the place, obtaining a reduction of the shunt, but he had no improvement. And really what happened at 3 weeks, he had the so-called melted brain. There is probably no more healthy brain in the head. So he died after a few days. Vein of Galen malformation used to lead to death in 90% of cases in the first month of life, and survivors would present major neurological deficits. But today, in the last 20-30 years, the endovascular treatment has allowed survival of 70-80% of cases with up to 60% of complete cure. So the conclusions are that endovascular treatment of vein of Galen malformation is complex, but can be done. It is necessary to be able to manage different endovascular techniques and to respect the extremely fragile structures and the delicate metabolic equilibrium. Thank you very much.
Thank you very much, Professor Komiyama.
Thank you. Thank you, Bigordi. We have one question from the audience. What's the best age or time to undertake the,
What is the best age and time to undertake patients for treatment of Galen malformation?
Mm-hmm.
The best agent, is
best
that the
age
question?
And time.
Age and time. Well, so as I said before, you have probably two different kinds of situations. One is very early at birth. Why? Because the fistula is so high flow that the whole hemodynamic of the whole body is challenged, and the heart is going to pump, but very soon it will become too much for the heart. So you have to do something immediately in the first days of life. But if you can wait, and you may help the heart with drugs, of course, sometimes you can prolong the need of treatment to 1 week, 2 weeks, 1 month, 2 months. So the more you can wait without having major complications is better. Why? Because the little kid will become a little bit bigger, larger. So also the arteries and the veins will be a little bit larger, and the resistance to any trauma will be higher. So everything becomes more easy to do and also more tolerable the more you wait. But I would not wait more than, let's say, 6 months, 7 months. When the child is 5-6 kilograms, then our procedures can be done with relative easiness and safety. And so at that time, I would treat. Why not to leave it alone? Because these lesions will damage the brain progressively. And once you see that you have a problem in the brain, it's probably too late to go back. So it's better to prevent any kind of brain damage by treating the fistula as early as possible. I hope I've answered the question.
Okay. Professor Bacardi, one another question about the transvenous access. You showed the first case. It was a staged. In the late stage, you use a transvenous approach. And one question, the primary transvenous approach is risky, or what do you think about the primary approach for transvenous?
Yeah, again, it depends on when and why you do the treatment. So if you go through the vein, it's to have a complete occlusion of the fistula of the lesion. And that may be too much in the very early stages when the neonate is very young. But it sometimes it's needed once you have to occlude the fistula and you don't have any more arterial accesses to the fistula, or they are impossible to catheterize because there are very many and tortuous and small. So the venous access is probably the only solution. It's a little bit more risky, again, because once you occlude the vein, you have to hope that the small arterial feeders to the malformation will not rupture, will not burst like in an AVM. Sometimes that may happen. You have hemorrhages because you have occluded the vein without occluding the arteries. That's like in a adult AVM. So you have to really check very clearly and well all the anatomical features, and they are all different. So every child is different, and there is not a rule which is good for everybody. But if needed, you can do it. I would not choose it as the first approach, though.
Okay, as you said, after several sessions, there are very limited arterial access. Then the situation that we have to choose a transvenous. What do you think? Which is better, to leave a little shunt as it is, or transvenous? With, I'm not sure you are very confident to successful, safe transvenous coil occlusion. When I was in such a situation, I'm not sure whether transvenous coil occlusion are safe for the kids.
Yeah, I agree absolutely. So it's dangerous to go transvenous, and we did have complications by doing that. That's why I can say that it's dangerous, because I did it and I was wrong, and we had hemorrhages exactly for that reason. So, but like in today's when we treat adult AVMs through the venous approach, there are situations where it's safer, and that is when you have the shunt is not big, so you don't have a lot of flow through the fistula, but just a little remaining flow, and the vein is not big, but it's small. So once you can have a very small residual thing, and it's much less risky. The good point you make is it really necessary to do it, or can you leave it alone and probably nothing will ever happen in the life of the child? Yes, probably we don't have the answer to this, because we don't have randomized controlled trials, or we don't have, thousands of patients on which to do this kind of reasonment. But you're right, it's better to be careful and cautious rather than to do something too aggressive.
Thank you, because we have another question from the audience. What is the suggestion when the lesion is ruptured or still has already the interventricular hemorrhage? The audience asking you.
Okay. No, vein of Galen malformation don't rupture, so you don't risk a hemorrhage in these cases. That's not their natural history. So we only have the consequences of a high flow shunt. And the consequences are both on the heart, of course, because it's a very high flow shunt, and on the brain, which is because of venous congestion. So the veins of the brain are congested, are full of arterialized blood. And so that's the reason why the brain is suffering. But they don't rupture. You won't have a hemorrhage from a vein of Galen malformation.
Right.
Okay. May I ask what last question? Okay.
Sure.
Okay. Because the last question from me, it's you say that the patient already brain damage, we do not treat, but the patient is not always the good or bad. In between, especially the neonate, it's very difficult to understand this is damaged or not damaged. How do you decide to treat or not to treat? In the area, especially in the neonatal stage.
That's another very good question. We, in general, we either have had death or we have had very good results. So let's say that the so-and-so results with something which is remaining in a patient who's not exactly normal afterwards is probably very rare. I think in probably less than 5% of cases. But what happened to us was just to have seizures, so epileptic seizure in the follow-up and in the growing older, which is something, of course, which is not good to have, but you can treat and you can still live with. So I think that we always do a good job if we treat, and if something has to go in the wrong way, it will go, and the little kid will die anyway. So I think it's reasonable to try to offer treatment in most cases, unless, of course, you see already a melted brain. So in that case, I would not.
Thank you so much. I completely agree with you. Okay, thank you. Thank you so much. So excellent lectures.
Thank you.
Thank you very much. It was a wonderful lecture. May I kindly ask one last question to Professor Dodi, that the BICETRE neonatal evaluation score system, how often do you include it in your clinical practice in the deciding treatment?
Never.
Never.
Me too. Me too.
No, I certainly understand where it comes from and why they did this kind of classifications and evaluation. Of course, it was very reasonable and all, but finally, you don't need any. I mean, even if you think that the situation is very severe, as I said before, if you treat the heart, then the patient will grow and will become a normal kid. If it's so severe, it will not even survive your treatment. So it's worth, I think, to try to save the child in most cases, even if the score is very bad, because you can still have some cases which will survive and which will go on to have a normal life. So I would not discard patients because of the score, which I did not include in my presentation.
Understood. Thank you. Thank you very much. It was indeed a mind-blowing presentation. We had a great learning from both of you. Before we proceed on to the second session, may I kindly inquire with both the speaker and chairs whether you will be staying back for the second session?
I hope so. I have a procedure in the angio room now, and I don't know if I have to go there.
That's okay. We are more than welcome to stay back. However, thank you very much, Professor Komiyama. Okay. I believe it's very late there. Would you be staying back?
It's okay, no problem. I will stay.
Right. Thank you very much. So before we go on to the next session, I would like to mention that this webinar is being broadcasted all across the world on different streaming platforms, and especially thanks to Professor Shubin, who has been from main mentor of ACNS webinars, and he has arranged a WeChat broadcast for today's webinars, and currently we have 930 people who are watching this live all across the globe in various streaming platforms. So we are largely indebted to Professor Shubin. So now we'll go on to the second session, and for which I would like to invite Professor Fuminari Komatsu to give the introduction part. Professor Komatsu.
All right. Thank you, Dr. Raja. I'm Dr. Komatsu from Japan. It's my pleasure to be our chair of this session. The topic of the second session is fully endoscopic microvascular decompression. We'll have the lecture from the Professor Wei Si in China. Endoscope provide excellent visualization and illumination even in the deep surgical field. The neurovascular conflict is well visualized under the endoscope. On the other hand, the technique itself is very difficult and the learning curve is required. So I'm looking forward to hear the lecture from the Professor Wei Si, how he conduct this procedure. So please start, Professor Wei Si.
Yeah, can you hear me? Can you hear my voice?
Yes.
Yes.
Yes. Okay. Yes. Thank you, Dr. Komatosu, and thank you for the invitation in this very excellent webinar. And this night, I would like to talk something about the full endoscopic surgery applied in the microvascular decompression for the hemifacial spasm and the traditional neuralgia. And just as we know that today the neuroendoscopy has been applied in many fields, not only including the ventricular surgery, the transnasal skull-base surgery, and the transcranial surgery, spinal surgery, and maybe in the future, the endoscopic surgery may be combined with artificial intelligence and the robotic assistant surgery one day in the future. And tonight, I would like to talk something about the cranial disease. Just as we know that the most common cranial disease is hemifacial spasm and trigeminal neuralgia and glossopharyngeal neuralgia. And the history of the MVD, just as we know that last century, 1960, Professor Gardner confirmed the reason of the hemifacial spasm of the visual compression of the nerve in the root of existing zone. We call it REZ. And Professor Janetta, maybe we can name him as the father of the MVD surgery, established and developed the theory of the MVD since the last century, 1967. Yeah, he is the first doctor to bring us the first introduction of microscopy to do the MVD surgery. And how about the endoscopy used in the MVD surgery? And we may divide into 3 stages. In the early 30 years ago, we can apply the endoscopy to observe and make the diagnosis during the operation. And about 20 years ago, some doctors have applied the endoscopy as a surgical assistant in the MVD surgery. It can change from the endoscopy to the microscopy, convert the microscopy to endoscopy to complete the MVD surgery. And recently, about 10 years ago, full endoscopy have become more and more popular in the MVD surgery. And but it's also controversial. And for the full endoscope surgery, some doctors had doubt about the efficiency of this surgical style. Yeah. For the hero Schroeder in Germany, he would like to apply using the endoscopic assistant way to do the MVD surgery. Yeah, Professor Schroeder will do the MVD surgery under the microscope, and then when he want to try to identify the offending vessel or the structures in the interesting space, he will transfer to the endoscopy and to identify the vessel and the nerves, the relationship between the vessel and nerves in the anatomical space. Yeah, you know. And after he confirms the folding vessels, he will then change to the microscope to continue the decompression of the surgery. And also, some also have published the paper in the World Neurosurgery that he applies the multiscopic technique. That means the endoscopy combined with the exoscopy to do the full endoscope surgery, and using endoscopy to do the surgery, and the exoscopy can observe the area behind the lens, so can eliminate the blind area of the endoscopy. Yeah. For the Peter Nakaki from the Bioneurology Institute, BNI, he published a book named Controversy of the Neuroendoscopy. In his book, in the chapter of the endoscopy used in applying the MVD surgery, he discussed the disadvantage and advantage of the endoscopy used in MVD, including the technical limitations, poor depth perception of the surgical field, and the endoscope ear occupy the space of the surgical field. Sometimes you know that the space of the posterior force is small, and sometimes the bleeding is difficult to control under the endoscope. But also the advantage of the endoscopy is obviously that it can provide the surgeon a superior image, and sometimes can reduce the retraction of the cerebellum or the neurovascular structures, and also to remove the skull base bone. Yeah. For the Professor Borghi, in his paper, which role of endoscopy used in applying the MVD surgery, his conclusion is two techniques should not be the competition, but the complementary. And the modern neurosurgeon should be familiar with both of them. So for the neurosurgeon, we should grasp the skill of the endoscope and the microscope. Yeah. And for Professor Yadav published the paper in the World Neurosurgery, I really agree with his opinion that endoscopic vascular decompression MVD is safe, efficient, and better alternative technique to the endoscopic assisted MVD. In his opinion, that full endoscopic surgery will must take place the endoscopic assisted MVD surgery. And the endoscopic assisted MVD also is an effective method for good microsurgeon, even if he or she is not familiar with the skill of the endoscopic technique. So so in our department, we do the full endoscope surgery from the 2017 to this year, and in 102 patients, 60 cases are hemifacial spasm, and 42 primary trigeminal neuralgia, and the complication including the mild transient facial pulses in 2 hemifacial spasm cases, and cerebrospinal fluid leak in 2 cases, and transient decrease of hearing in 1 hemifacial spasm. And but I want to mention that all the cases occur in our first stage in this series. And there are 2 trigeminal neuralgia cases had no relief of the pain, and 1 hemifacial spasm had only partial spasm relief. And also these cases occurred in our early stage of the early 50 cases. Yeah, here is the arrangement of our operation room. And here I want to mention that in our series, I would like to using the way that the assistant holds the endoscopy, not the pneumatic arm holder. I think that if the assistant holds the endoscopy, can that on one hand that's stable, and another hand is easier to move out or put in the instrument during the surgery. And it's the operation procedure of the full endoscopic surgery MVD. We're also using the retrosigmoid approach, make about 3 to 4 centimeter diameter craniotomy, and the neuroelectric physical monitoring, the lateral spray response, are very important to the surgery when we perform the hemifacial spasm decompression. Yeah. And the anatomic structure in the CP angle, CP angle region is very familiar for us, and we can divide into 3 space, just between the 10 to the cranial, the 5th cranial, and the 5th cranial to the 7th and 8th cranial, and the 7th cranial to the 9th cranial, and each space we can apply to do the MVD surgery. And it's intraoperative pictures under the endoscopy observer. We can find that the endoscopy can provide the neurosurgeon very sharp right-hand panoramic images during the MVD surgery. And I would like to show some cases. The first one is left hemifacial spasm. This case is we just perform the full endoscopic surgery. It's really a video that we do the surgery in the under the full endoscopic surgery, and after we have completed the decompression of the facial nerve, we then convert to the microscopy to compare the exposure of the surgical field under the endoscopy and the microscopy. So from my left hand is the endoscopy, we can see clearly that it can bring us a very nice, very excellent intraoperative exposure. When we using the 30-degree endoscopy, we can easily to expose the area of the facial nerve, and we can find that the vertebral artery and the TCOM are the offending vessels, and we can separate it from the REZ of the facial nerve, and it's easy for the operator to do the MVD surgery. However, we in my right hand is a microscopic surgery. We can easily draw a conclusion that in the same patient, we using 2 different exposure tools. We can draw a conclusion that the endoscopic surgery can provide more superior image of the surgery. So it's very interesting, yeah, in this case. Yeah, the AV decay of the neurovascular structure exposed under the endoscopy. And there are some difficulties in the full endoscopic surgery of MVD, and such as the blocking of small branches and of the vessels, or the vessels ventral inferior compression of the ventral part of the cranial, or the small CP angle system space, or the vein compression of the cranial nerve or multivessel compression, I would like to give some cases. The first one cases is the left hemifacial spasm. In this cases, we can see that the vertebral artery were blocking the exposure, and the ACA loop compress REZ of the seventh cranial nerve. It's a female lady. Yeah, I can show the videos. And we would like to we would like to open the arachnoid first. We do not use the retractor in all my operation, and we just open the space between the 8th and the 7th nerve and the 9th nerve, and we use the microsector to make the sharp dissect of the arachnoid to expose the space. And we using the suction to gently retract the cerebellum. Do not use the retractor. Yeah. And then we using it's a 0 degree endoscopy exposure. And then we change to the, yeah, it's a 30 angle degree endoscopy, can expose the interest space of the root of the facial nerve. First, we think that the vertebral artery may be the offending vessel, but however, after we detect the error, we can find that also the ACA loop also compress the REZ. So in this case, that's the vertebral artery combined with the ACA compress the REZ. So if we just decompression of the vertebral artery, I think that the operation will not success. So we mobilize the ACA loop, and we can ensure that the ACA loop has enough space, and then we between the REZ and the artery, and then we put the Teflon pad insert into the artery and the REZ region. So it's easy for the operator to do the surgery under the endoscope. You know that we would like to use in the 2 hands surgery. One hand hold the section, and the other hands using the micro dissector to in this stage we adjust the position of the pad to a right position to confirm that we can complete the total enough decompression of the facial nerve. Yeah. And this patient is also 56 years lady, and he suffered for the left hand hemifacial spasm, and in these cases, we can find that ACA blocking the exposure, and also 2 offending vessels compress the REZ region. And here is a video. Yes, when we open the arachnoid in the CPA and cerebral puncting angle region, and we can find that the ACA blocks the expose of the deep space under the facial nerve. And first we have to mobilize the ACA and get enough space. So we try to cut off, open the arachnoid around the ACA. And then the ACA can be mobilized. Then we can put the endoscopy 30 degree angle endoscopy to the cross the furculus and to the region of the fissurous nerve root, and we can expose the vertebral artery and the pica, and then we use the micro dissect to separate the artery, the pica, from the REZ region, and then we insert the Teflon pad in the space between the nerve and the artery. We can ensure that the decompression is completely under the endoscopy. Yeah. And the third one is also a male, 61 years old, except for left hemifacial spasm, and the ICA loop compress the REZ region. For the time limit, I will not show the video. And the first case is a female, 62 years old, also left hemifacial spasm. In this case, the branches of ICA compress the REZ, and I can show the video. Also, we using the micro scissor to open the arachnoid and expose the space between the ninth nerve and the 7th and 8th nerve. And we then change to the 30-degree angled endoscope to expose the REZ region. And we can identify that the ICA and its branch looks like a Y compress the REZ region. So it's very clear, and the neurovascular structures can be exposed clearly under the endoscopy. So it's safe and it's efficiency, I think, to do such a operation under the endoscopy. So, and then we put the Teflon pad. You can see that here is some small bleeding here when we insert the Teflon pad, but we should not nervous, and sometimes the bleeding may stop itself, and the Teflon pad also have the function of the hematosis. So after we have totally decompression of the vessel, the bleeding stopped. So it is a successful surgery. And also, in this case, right hemifacial spasm, it's a very small CP angle space. Also, two offending vessels. So vertebral artery combined with the ICA compress the hemifacial, the REZ of the 7th nerve. And we can see that after we put the cotton pad to protect the cerebellum, we expose the CP angle. It's very small in this case, and the posterior force is more, but it's not a problem. We just need a patient to open the arachnoid, and we can expose the ICA in the space, and we should open the arachnoid completely, and under the exposure of the endoscope, some small branches from ICA can be identified, and we should protect it. And then we can expose the root of the fissurous nerve. The first one is the expanded vertebral artery compress the REZ. But when we lift off the artery, the vertebral artery, we then can expose under the endoscopy another vessel artery. It's the ICA, also compress the REZ region. So it's the two vessels, two arteries compress the fissure nerve. So we should decompress both of the vessels. That can ensure the result of the operation. So we use the micro detector to lift off the two vessels from the REZ. And after we lift off the arteries, we can expose the REZ region. It's clear here. Then we put the Teflon pad into the space between the artery and the REZ, the root of the fissure nerve. We put one, and then we can put another one to make ensure that the decompression is complete. It's the second Teflon pad, and then we can put the third one. That is the third one. Yeah, after we have insert the Teflon pad, finally we should check the result of decompression. We can see that the REZ region have been totally separate from the vertebral artery and the ACA. Yeah. So here's another left hemifacial spasm. Also, it's a expanding vertebral artery combined with ACA. For time limit, I will not show the video. And this patient is a secondary hemifacial spasm with right acoustic neuroma. We also do the resection of the acoustic neuroma using a full endoscopy. This patient is male, 54 years, suffer for the right trigeminal neuralgia. In this patient, that the offending vessel, supracerebral artery, compress the cranial nerve, fifth cranial from the ventral inferior aspect. So it's sometimes difficult for the decompression of this in such a case. Yeah. So first, we also open the arachnoid. For some small branches from a small artery from the arachnoid, we can coagulate and cut it off. And some small bleeding in this situation, we can use a bipolar or using the irrigation to stop the bleeding here. The small vessels in the arachnoid, you can see that irrigation can stop the bleeding. Then we open the arachnoid above the fifth nerve, and we can expose the petrous vein. It's very important to protect the petrous vein in this surgery. And then we open the arachnoid totally using the sharp dissection, and some small branches should be protected. And we put in the endoscopic, can expose the fifth nerve, trigeminal nerve, that we can find that the SCA compress nerve from the inferior, the ventral inferior aspect. First, we use the dissector and the section to separate the artery from the nerve. We can break the bridges from which junct the artery and the nerve, some arachnoid bridges, and we separate off the artery from the nerve to make enough space, to create enough space to put the Teflon pad. And Here we can see that enough space has been created. And we put the Teflon pad in the space between the artery, the ACA, and the fifth nerve. It's the first pad, and then we put the second one. We should make sure that the trigeminal nerve have been decompressed totally. The whole length of the fifth nerve have been decompressed. Here we can see that the ACA have totally been separated from the nerve. Yeah. And this patient is also an old lady, 66 years old. He also suffered from left fissure, knife cut pain, left trigeminal neuralgia. And in this case, also offending vessel is also SCA. And we do the operation, the MVD, using the bridging separate method from both sides of the fifth nerve. Yeah, I can show you the video. Yeah, but also we using the micro caesar to open the arachnoid around the fifth nerve, and we should also remember to protect the petrous vein. And here we can expose the trigeminal nerve, and we can find that under the endoscopy that the ACA compress the trigeminal nerve from the inferior ventral aspect. So it's difficult to remove the artery. So we try to use a bridge method. From the upside of the trigeminal nerve, we separate the artery from the nerve. We can find that under the exposure of the endoscopy, some small branches can be exposed very clearly. So it's the advantage of the endoscopy. So we should protect some small vessels. It's a small vessels branches of the artery. And after we have separated enough space, we may put the Teflon pad in the space between the artery and the fifth nerve. Sometimes we would like to use the micro detector to lift to separate the artery, and we use the section, a very small section. The diameter of section is 2 millimeters, to put or insert the Teflon pad into the space. Occasionally, there's some bleeding when we insert the Teflon pad. In this case, we can find that small bleeding here. Yeah, when we insert the pad, small bleeding here. So there are no need to be worried about it. We just use usually we just use the irrigation to stop the bleeding of a small vessel, a very small vein of the pons. After we irrigation, the bleeding can stop. Yeah. And then we put the second one. After we have separated the upside, we then turn to the lower side of the fifth nerve. Also separate the artery from the nerve root. And we also put the Teflon pad in the space between the artery and the nerve. It's the first one. And then we insert in the second one. It's the second one. So just like a bridge, we can lift the fifth nerve up and separate it off from the ACA. So I don't think it's very difficult to do such an operation under the endoscopy. Yeah, two-hand surgery. So it's a nice picture here. And the last case I want to show you is venous, Petrovenous infraction, compression of the fifth cranial. And it's also a very difficult case. You know that the wall of the vein, Petrous vein, is thin, very thin. So it's very difficult to protect the Petrous vein when we do the separate the vein from the cranial, the fifth nerve. So after we open the arachnoid, we can expose the fifth nerve here, and we can also find that Petrous vein, the branches of Petrous vein, compress the nerve from the ventral inferior aspect. So it's very difficult. First, we open using a micro dissector, open the arachnoid between the vein and the nerve, and we try to make a space to separate the vein and the nerve, to make a space from both sides, upside and the lower side. Yeah. So when we create enough space here, it's the upside. Also open the arachnoid in the fifth nerve. And when we create enough space, we can find that here the vein have been totally separated from the fifth nerve. Then we insert the pad, from pad. In this moment, it's easy to do the insert the Teflon pad because we have separated enough space. Yeah. And we also some other cases also Petrous vein compress of the fifth nerve. And in this case is SA combined with the suprapetrous vein compress the fifth nerve. We do the decompression of both of the vein, both of the vessel. And this case is have some small branches. You know that you can see from the pictures here, from arising from the SCA. So it's very important to protect these small branches when we separate artery from the fifth nerve. And this also SA compression from the inferior ventral aspect of the cranial nerve. And last one is Pex meningioma, Petropex meningioma, also a secondary left tumor neuralgia. She's an older lady, already 89 years old. So we do the operation to resect the meningioma on the full endoscopic surgery. And this patient is geniculate neuralgia. We do the surgery under the endoscopy. Yeah, it's a picture of the surgery. So summary. First, I want to say something about the surgical technical tips of the full endoscopic surgery in MVD. First one is optimal cerebrospinal fluid release. It's very important to ensure the adequate brain relaxation, and the adequate mobilization of the offending vessels from the nerve. And the two-hand surgery is a critical factor in the full endoscopic surgery applying the MVD. And also we should remember that we always should avoid the sacrifice of venous structures. It's very important to protect the Petrous vein. And using angle endoscopy in our series, I would like to use a 30-degree angle-scopy to eliminate the block of sometimes the petrous bone or the torticolor of the internal meters, and expose the data cord, look around the cord of the interesting space. And enough micro instrument used in the applying the endoscopy, not the microscopy, should be prepared. Sometimes the micro instrument with gentle curved tips. And our conclusion, although some we can see first the advantage, endoscopy can provide a comprehensive panoramic and excellent visualization to lead to look around the corner and enhance the identification of the offending vessels, especially to expose the ventral inferior aspect of the nerve, no matter the facial nerve or the treatment nerve. And under the endoscopic surgery, minimal cerebral or folliculus or the neurovascular retraction is needed, and less bone removal is needed. And also some disadvantage, but I think the disadvantage should be to the individual, to different opinion of the surgeons. Yeah. First one is a poor depth perception of the surgical field with 2D, two-dimensional view. And the endoscope will occupy the working space and obscure the operation field. And also endoscopy exists the blind ear behind the lens. So when we put in the instrument or move out the instrument, sometimes it's maybe damage the neurovascular structures. It's dangerous, yeah, sometimes. And a steep learning curve along long-term endoscope training is also needed before we try to apply the endoscopic surgery in the MVD. And the bleeding sometimes may be difficult to control. However, also we believe that larger controlled prospective studies are needed. And no matter what microscopy or endoscopy, they are both imaging tools, used for imaging tools for the neurosurgeon. So endoscopy serves as a valuable adjunct to microsurgery. So I think that all the neurosurgeons should be familiar with the endoscopy. Despite of the limitation of endoscopic surgery in MVD, endoscopy remains a valuable adjunct to the neurosurgeon who are heavily on the microscopy. So for the very experienced neurosurgeon who are familiar with microscopy, I think that he or she should try the endoscopy in the future. Yeah. As the development of the technique in the endoscopy itself, full endoscopy as a sole source of visualization will gradually take center stage, not only in the MVD, but also in other complex scale-based minimal surgery in near future. It's my opinion, it's my team opinion. Yeah, that's all. Thank you.
Thank you very much, Professor Komatsu. You can take over.
Yes, thank you, Professor Weisi. We have some questions from the audience.
These questions were already answered in the lecture. That's why we removed it. Yes. One question was about exoscope. How would you find that exoscope would take over endoscope in the future? What is your opinion? Both Professor Komatsu and Professor Weisi.
Yeah, you mean the exoscope and the endoscope. Yeah. We do the operation transcranial surgery using the endoscope, but some doctors use the exoscope. But I think that for the very deep surgical field, the exoscope cannot give us a very clear exposure. So I think the endoscopy may be the best one. And today we have a 3D endoscope. We can take a pair of glasses. But I think exoscope, I have tried the exoscope in the skull-based surgery. I don't like the exoscope. I would like using the endoscope in, yeah.
Okay. Professor Komatsu, your opinion?
Yeah, my opinion is almost same. The endoscope and the exoscope is completely different modality. The endoscope, we can see the neurovascular structure near the object, but the exoscope is almost same as the microscope. It's
Yeah.
the resolution is better than endoscope, and also the manipulation is better than endoscope. But I think for the microvascular decompression, I think the endoscope is better than exoscope. That's my opinion.
Thank you very much. Is my co-host Liu Bun saying?
Thanks, Raja. Thanks, Professor, for a very nice talk. I have two questions for you, Professor. First is in recurrent cases, if you have encountered, how do you deal with the Teflon? My first question. Second question is, do you always have a separate set of instrument that when you use 0 degree and 30 degree scope as a reminder of your trajectory of your instrument? Thank you, Professor.
I'm sorry, I cannot hear you clearly. Yeah.
Liu is asking about recurrent cases.
You are talking about the recurrent case.
Yes, recurrent.
Okay. I think, in my opinion, in recurrent case, the operation is completely different from the initial case. So
Yeah.
So in the recurrent cases, I think the more fine manipulation is required rather than visualization. So that's why in my institute, I prefer to do the endoscope assisted microscope surgery. So we use the endoscope at some point, but mainly the microscope surgery is required to release the adhesion and to remove the adhesion of Teflon or something like that. So I think so surgery is different in different cases. So that's my opinion.
Thank you very
so
much.
that I agree with the opinion that recurrent cases is difficult for the operator to perform the surgery. You know that the anatomic structure is totally different from the initial cases. So it's maybe a challenge for the neurosurgeon to do the recurrent surgery, not much under the microscopy or the endoscopy. Yeah.
Right. Thank you very much. May I also kindly inquire with Professor Weishi that the current trend of removing vessels away, gluing the vessel to the basal dura. How often do you practice?
You're talking about the transposition technique.
Transposition.
Yeah.
Right.
We have the two different type of the decompression procedure: interposition or transposition.
That's correct.
You also want to ask
how often Professor Weishi practices transposition?
I have some opinion with Dr. Komatsu. Yeah.
Professor Komatsu, I think it's time we can wind this up. You may kindly say your concluding remarks.
Yeah, so thank you, Professor Weishi. For me, the teamwork between the assistant and you are impressive for me. The visualization very good. So thank you very much.
Thanks. Thank you
very much. I think it's time we can wind this up. I'll wind this up officially now. On behalf of the Education Committee of the ACNS and the President of CUPAT, I would like to thank both the speakers of today. I can see Professor Eduardo Boccardi and Professor Komiyama still with us. Thank you very much, Professor Komiyama Sensei, for staying back so late. We are extremely grateful to you. So it was a very wonderful lecture by both Professor Eduardo Boccardi and Professor Weishi. We are extremely thankful to both of them and the chairs, Professor Masaki Komiyama and Professor Fuminari Komatsu. I would like to sincerely thank Professor Shubin for his continuing support and allowing us to reach a wider audiences in China Today we have around 940 viewers finally who joined us live for this webinar. Thank you all the wonderful audiences from different parts of the world who have joined in. Thank you, my dear co-host Liu Boon Singh, for joining me for this webinar. So now until we all meet on the 4th of September, it is bye-bye from everybody. Thank you very much for joining.